Okay, thank you everybody for coming, taking a little time out of your busy schedule. Technology is a great thing when it works for you, but man, it can sure mess you up if you don't have everything in place. So we got Dr. Losey on the phone here. I may have to hold him up to my mic or whatever, and we'll see what we can do here. What we're going to be talking about is Texas epidemiology updates and how we're working and striving to become the best in the West. So what we're talking about here is diagnosis and deaths and people living with HIV. It's kind of a peculiar chart. This is actually read this way, and so that would be roughly 4,500. And then up in the near 80s there, and deaths over here roughly 20,000, and you can also read it off this side per new diagnosis death occurrence. So it's kind of a peculiar chart. I didn't make it, but I'm just trying to work with it. So in keeping with that, what we'll talk about now is the reported cases in 2014. This is for Texas-wide. I'll talk a little more about the demographics and data when we get closer to Lubbock and Amarillo and El Paso. So you can see here HIV accounted for about 4,400 cases. Chlamydia, probably all-time high, and gonorrhea, 34,400 some cases. Syphilis, 3,000 plus cases. So one of the things to keep in mind here is that gonorrhea is developing resistance to classes of drugs that are used to treat it, and it's becoming more prevalent. DSHS has recently issued a letter talking about how prevalent it is and actually how much of an issue it has become, so and new treatment guidelines for it. And that's available on the website. As of 2013, you can read there, we're pretty much in the lead. Texas had probably about a fifth of the total congenital cases of syphilis reported in the US. Okay, so now all the shock values out of the way. We'll talk a little more about epidemiology. This is the part here that we talk by age breakdown. You can see across here 20 to 24, that typically accounts for the largest number, and the reason for that is those are the kids that are in college, they're experimenting, they're away from home, doing all the things that kids do. And we also have this broken down by race, ethnicity, female, male. But this is really the age group that I'm very interested in right here, and part of that is because of the risk that they take, risk-taking behaviors, and what my position is to try and avert that risk. I think that if we do some intervention here and try to avert some risk-taking behavior, that can actually offset some of that. But interesting how they've broken this down now a little bit, but we can talk more about that later. So this talks about Texas new diagnosis and rates by year, and you can see that's pretty consistent with what we said earlier in that breakdown, Texas-wide. There they are down at the bottom. If you have a question about any of these graphs, some of them are represented in different ways. It's the same information, just different ways, so I'm happy to explain it, okay? You can see here there's still a huge disparity with the black African-American population, and then next Hispanic and white, followed by all other Asian, Island Pacific, etc. And now we move into new diagnosis rates by sex and year. Here you see that this is pretty much remain the same, but you can see there's a huge difference between male and female. And that's because of the whole issue with men having sex with men, and also living a heterosexual lifestyle, or engaging in risk-taking behaviors as well. Okay, HIV diagnosis rates among persons 15 to 34. And again, I have particular interest in this group, and there still leads the way. Interestingly enough, over 40, 45 and up, because of the amount of the divorce rate, they're single again, entering the dating scene. You see a slight rise in that population as well on the other end, and you'll see that in a bar graph here we'll show. And there they are over there. again, this is a particular interest for me, and if you took this off and put it over here, that would still be pretty much that number. I mean, that's how big of a difference that. It doesn't really make that big of a difference, but it's actually in between here to here. That's very concerning. It's just not well represented by this graph. So new HIV diagnosis by mode of transmission. What we're looking at here is men who have sex with men, IV drug use, men who have sex with men and IV drug use, and then heterosexual. You can see a lot of times the misconception is that IV drug use is usually this huge problem. It's more so with hepatitis than HIV necessarily, but you see here it's men who have sex with men are grossly affected by that. So then new HIV diagnosis by mode of transmission and sex. You can see the huge difference in the number here. And male, female. And the representation there of the different breakdowns.
Wow.
I heard a wow. Okay, so again, this is kind of a different representation with a bar graph. And I'm very happy that they're now representing TDCJ there at the end. Previously, none of the data collected was ever inclusive of the prison system, and I think that's a fantastic inclusion for them to do. So here you see the rate of new diagnosis in men who have sex with men, and there again, the disparagement in the Black, African American, Hispanic, white, and all other. Okay, then categorically stage 3 HIV/AIDS infection is categorized by these diagnostic criteria here. And the interesting thing about working with Dr. Alozzi and in the El Paso population is a lot of times because of the cultural aspects, what happens is these folks will come very late to care. And I mean, they're practically with pneumonia or having some very, practically on their deathbed, I mean, for lack of a better term, and get put in the hospital, find out they have like PCP pneumonia, and they're in AIDS. So kind of a cultural aspect, a lot of other factors too, but really a heavy cultural definition there, yeah. So I just throw that in there, but also here, in keeping with that, the late diagnosis factor here, like I was talking about, tends to remain pretty much the same. You see if you had a breakdown of Hispanic and different ethnicities, that would probably be about the same between Black and Hispanic, but this is a general representation overall. Still very high. People just aren't getting into care quick enough, and that's the whole reason that we'll talk about some of this stuff in the end here. Hey, Dr. Alozzi, whenever you're ready, just let me know, and I'll let you talk. And I know you have to go pretty quick, so still there? Okay. Well, we'll keep on then. Okay, so I think he's on, but he may be talking to somebody else. He's got like two. Okay, so back to TDCJ here. I'm glad that that's represented. Also part of the late diagnosis, and we're actually working. My team and I are working with the prison system here to actually help to try to set up something for capturing those folks when they come out of the prison system back into society, so that they can be brought into services quickly upon their release. So talk a little bit about people living with HIV. This is the total number here represented, and then that breakdown is male and female, and then by race and age group to get your total there. And there's the rate of diagnosis there. Okay, then prevalence of rate with people living with HIV by gender. Again, this is a graph that's just a different representation of what you were seeing there. Female, male representation. You see it's quite a bit higher, just as we demonstrated earlier. So in that very first graph, you saw that people are living a lot longer because the drugs that we're using are working. If they're taking their medicine, typically it'll be their genetics that would be their demise. I mean, you know, blood pressure, diabetes, those kinds of things that would be their demise rather than HIV. So that's why you're seeing that line spike up. Now, one of the things, if I laid over a funding stream of like how DSHS and you know, the feds fund us, it would practically stay the same the whole way across. But all of these folks are living longer, all of these new diagnoses, right? But our funding has practically stayed the same. So that's a big issue. And as you see here with prevalence of HIV, prevalence of rates of people by ethnicity, this population, the black population, is really very disproportionately represented by this. I mean, they have a huge factor. And the disparity is like really out of control. I mean, it's astronomical now. We deal a lot more with the Hispanic population based on where we are in El Paso, Midland, Odessa, Lubbock, and Amarillo. But again, you know, this population is severely affected. The mode of transmission for people living with HIV up through 2014, men who have sex with men accounted for the largest transmission. IV drug use, MSM, ID drug use, heterosexual, pediatric, adult, other. So there you see the accounts by men who have sex with men, intravenous drug use, broken down by number. And then these are the total occurrences, so not to think that that's the actual number, but this is the total diagnoses across the board. This is our number here that we're living with right now. Okay, so HIV related deaths. See, male accounts for more in that population as well. Female accounts for fewer deaths up through 2012. And the thing is death rates lag about 2 years anyway. I noted that in one of the slides. And epidemiological data is typically about a year or two behind as well. So we I just kind of have to stay on top of this and keep after DSHS to send it to me as soon as I can get it. So rate of death due to all causes, just a general representation. And that's represented by that number, you know, the red line that we showed early on. Rate of death among people living with HIV and mode of transmission. So if you were an MSM, MSM, pediatric, intravenous drug use, but you see they all trend down because the medicine that we're using works. I mean, they take their medicine regimen, chances are they'll live a happy life. Now we get into some regional data. We are represented by region 1, 9, and 10. That's El Paso, Midland, Odessa, Permian Basin, all the way up through the smokestack of Texas, Amarillo, all the way up to the panhandle of Oklahoma there, okay? So region 1, you see here is represented, and then region 9 and 10. So see, it's generally about the same. I mean, you've got some of these other regions like Houston, Dallas in here, so that's where these big numbers come from. Okay. And there's Lubbock. And here we are on this side by number of people living with HIV, new diagnoses. Now, interesting enough, you'll see here El Paso County. Okay. And then all the big counties, Harris, Dallas, Bexar, Travis. But, you know, to be in the top 15, I mean, that's pretty impressive for all the wrong reasons. And then you see Amarillo and Midland, Odessa are not listed on there. Here is an interesting slide, and the reason I say it's very interesting is because Frio is listed as number 1. Anybody ever float the Frio River? You know how many people are in that county? The whole county? About 21,000 people. So that's hugely impressive because if you figure that out statistically, that means that about 11 people got HIV this past year, and there's 89 people living there with HIV, which is, I mean, very bizarre to me. I asked DSHS to clarify that because it was very unusual, I thought. Again, making headlines for all the wrong reasons there. And all the bigs. All right, and then talk a little bit about HIV with origin. You see Mexico leads, especially in our region, because we have a big cross border there. And one of the interesting aspects about that is we have about 700,000 people roughly in El Paso, and then you got 1.2 million on the other side. But no one really takes that into consideration as a whole, like a metropolitan area. What they do is they divide it and just say, well, we're worried about the Texas incident. Well, that's a very fluid border. There are people coming back and forth all the time. But here you can see a great representation of all the different areas. So these are the case estimations, and like I said earlier, we talked about, it was right in here based on what our prediction was on that data. Now this is pretty new and accurate data right here, talking about what their estimation was, what their low was, and then the median, and that's the number they ended up with after their high-low. So now, talk a little bit about becoming the best in the West, right? Part of the reason I have Dr. Alozi to talk with you is because he talked to me one day about going into a private practice setting. And we got to talking about this conversation, and for the life of me, I don't think that in anywhere else in Texas this has been done, but we took a private practice, we took a case management service, and a 340B pharmacy entity, and we put them together in this integrated practice. And anybody know what 340B pharmacies do? So if you have mixed payer source, or if you have dual eligible folks, Medicare, Medicaid, or and private insurance, they will rebate the practice about $7,000 per person. So if you have private insurance, it's roughly $700-800 rebate from the federal government. So what that amounts to is that this is a funding stream that you don't have to answer to DSHS to. You can offset and augment this source of income that's relatively stayed the same, and use this for all types of patient good, for practice good, for everything. They have a very unique multidisciplinary approach. They have a PharmD, case manager, and physician who work together to implement the best practice that we feel like.
Is it HRSA grant funded, or how's it funded?
So comes from HRSA, goes through the OPA, which is the pharmacy regulators. You register, you basically go through a registry process, and they just added another pharmacy to their array. So now the clients have a pretty good little choice of providers, if you will, for pharmaceutical benefits. So now on the client end, what happens is you get basically all your meds shipped to your home or to your provider or wherever you need them sent to. And they're packaged, they're labeled. The pharmacy collects data on when you refill, how often, what drugs you're taking. And it's not just HIV meds. It could be other meds as well. But that is the beauty of it, is because now you have a mechanism to keep people engaged in care and retained in care. So we worked on linking in a couple of presentations back, and now we're working on retaining, because we see that if you get them early into care and you can retain them, you get them engaged in their care and retain them, the likelihood of that line being shot straight up like that with people living longer is increased astronomically. Everybody following me? Okay, cool. So that's what we did, and we liked it so much we decided we'd do like the largest regional collaborative. So we got Amarillo, Midland, Odessa, everybody on board. We're just waiting on Amarillo. I think they're going to come on board this January. It'll be the largest regional consortium. Then Project Champs, the provider for case management services in this private practice, have partnered with SPCAA, which is their parent company, and 96 other counties to create the largest collaborative federal navigator consortium. So now you have people who are assisting people with HIV, with any other, federal exchange system insurance item or enrollment or re-enrollment. But particularly people with HIV, if you don't sign up for the right plan, what ends up happening is they may not pay for your meds, right? They may not pay for the specific provider you need to go to or that you've been seeing before. So it's a very unique system, very unique program that links together two big federal programs and allows for people to get into care the way they need to in an appropriate insurance program, so that if you have, and this is another thing, if you have a lawfully present person who's not a citizen, but they're here lawfully, they can actually enroll in another program that can get them a policy that's like $20 a month and pays it's like $2,000 out of pocket. Now that offsets the expense greatly, right? Because those of you who are in hospital administration roles, how much reimbursement do you get from people who are here lawfully or undocumented or any?
Zero.
Big goose egg, right? So yeah, we found a way around that. So it's really unique, really interesting program that we put together. We're now working with Forward Health Data System to pilot a program. Dr. Alozi is gracious enough to take that on. And this makes us directly visible to HRSA, which sort of just negates the need for DSHS to even audit us or audit our provider, because this software can make them visible to HRSA directly, which reduces manpower and any number of cost savings for DSHS. There's been a lot of review lately, sunset review and things like that going on. That's something that happens every now and then with DSHS to see if they're needed or state grant programs are needed. So if they are, let me take that back, not state grant programs, but state programs, whether they're needed, useful, and they're doing something with the money they get, right? Okay, so that element also gives us real-time data that we can look at with our clients, our patients, right? And then the Texas HIV treatment cascade implementation, I'll show you that and what it looks like. And then we have the housing opportunities for people with AIDS, collaboration with the city of El Paso. So now the grant money that comes through the city of El Paso, that HOPWA system, the housing opportunity system for people like with HIV who are disabled or need housing assistance, right, maybe homeless or something like that. We've merged that with the HOPWA grant that we use to fund this system. So now you have the city of El Paso working in collaboration with Project Champs, these folks here, the case management system. So they can be followed together as an integrated system. So we've done a whole lot of work out in El Paso. I've spent a lot of time out there to make this all come to fruition. And Dr. Alozi has done a lot of footwork, and he's done a lot of ground pounding to get a lot of this stuff done. So this is what the Texas HIV spectrum looks like, the engagement. First was public awareness, targeted prevention, full diagnosis, successful linkage, which is where we kind of are right now. If you've kind of followed my talks, this is kind of the movement that we were going in. We're here, we're working on this, and that's where we're at right now. And all of this is in conjunction to achieve viral suppression. Because if you're virally suppressed, the chances of you transmitting the virus are very low. I mean, 0.000, that kind of stuff. Okay? So this is what the Texas Cascade looks like as a whole across the state. Estimate of HIV individuals, known and unknown, right? And they estimate this is about 18%, okay, of the population is what you don't know about. The ones that don't know they have HIV, okay? Much higher than we initially thought. But anyways, that number comes out to about 89,000 roughly. Living with HIV at 2012 was about 72,000. This is the number that had needs met in 2012, which were length of service, linked to other systems that they need. 2 or more visits in the 3 or 6 month period to their provider, and then those who achieve viral suppression. Now, ideally, we would want this up here, right? So whatever's coming into care, we want that to match, right? But you see, that's been a big issue. So this is what it looks like in Amarillo. Roughly 55%, yeah. And then this is what it looks like in the Permian Basin, right around 48%. And El Paso, doing great, 54%. And Lubbock, roughly 54%. So if we go back here a little bit, and I'll show you, we're well above where the state is as a whole. And I think that speaks volume to us becoming the best in the West, right? So particular interest to me, again, I talked about risk behavior. I think that a lot of the factors that we're seeing play into this, 11 to 15-year-olds versus this 45-year-old population with other issues and aspects on the other end of that spectrum, right? But I think by going in and averting risk, looking at risk, taking a better look at risk, then we can help avert that some. The other thing is e-cigarettes and that sort of stuff that's coming out. I mean, it's candy-flavored stuff. It's all geared towards children, young adults, that sort of thing. It's like the old advertising gimmicks of the regular cigarette days. If you look at them, they're all cool. It's young guys with shirts off smoking these e-cigarettes, you know, that kind of stuff. And it's all geared towards kids. It's geared towards young adults. I mean, who wants to smoke pineapples? And who wants to smoke, like, you know, candy, cherry cotton candy or something? I mean, that's what it's for. Let's be real. So culture of child sexualization. Take a look at, like, the pop stars of the 90s and take a look at the pop star females of this era. And they're big, there's just a stark difference. Debbie Gibson versus Miley Cyrus. Probably best example I can give you right there. It's a culture of sexualization that we're making it okay. Okay? And it's happening in commercials for her, happening in commercials for him. It's how intelligent or how handsome a young man is, or manly, or this sort of thing, but it's how, oh, look, play with this cooking set, and how beautiful you could be. Oh, it's all about makeup, it's all about this, all about that, right? It's all about that image that's being portrayed for a child, right? YouTube, Facebook, all of these things are really factors in their era, their culture as they grow. Adverse childhood events. There's a real interesting tool that you can take and stick into a private practice, plug it right into a private practice. They can use these indicators to look at risks that children have from early childhood, witnessing a death, witnessing something violent, sexual abuse, all those things like that. Those things can be factored in, and they can look at risk early on, and they can follow a child, or they can help to avert it. This is just an easy little tool that you can plug into a primary practice. Narcotic abuse. The way that this works is like mom, grandma has a bunch of codeine left in her, because you know they give her the jug of codeine, right? The Sam's bottle of codeine. And so grandson comes over, picks that up, sells it to his buddies for $5 a pill. Then his buddies get hooked on it, and they can't find it anymore. Well, guess what the cheap alternative is? Heroin. So that's what they get hooked on. And this is becoming a big, big problem. Think about Plano here a while back. Black tar heroin was a big deal there. And no one thought that in that affluential neighborhood that would be a problem. And that's probably 5 years ago. Now it's reoccurring. Now it's a big deal. Now it's an issue. All these things are in this group. All these things are happening. So what's new about all this, right? Well, the incidence of HIV and STI transmission and the correlation to media venues called hookup apps. That's what I'm following. That's what I'm going to be looking at the next time we have this little chat. That's what I'll be talking about. So I betcha, just betcha, that if I take and I see all these new incidents that are coming in and I ask them, well, hey, do you use Tinder, Grindr, any of those things like that? Do any of y'all know about these? Those two are pretty common, right? Yeah, they're used for the same thing. A lot of young kids. They're used to get tattoos. They're, you know, hey, I got an opening, come to my basement, I'll hook you up. Happens all the time. Grindr is a app for homosexuals to go and actually, you know, it pings a person who has that app, and you can find where they're at. If you want to hook up, you can hook up. If you want to have drinks, if you want to whatever. But typically that's what it's for. This was renamed to Down because iTunes had an issue with their previous name. Can't imagine why. But Pure, Tinder, Scout. Anybody know what Netflix and chill means? Better learn the lingo of your kids, because Netflix and chill means a whole different thing. Let's watch Netflix and chill. That means come over and let's hook up. Folks are away, that sort of thing. Okay? So learn the lingo. In other talks that I've had, I've talked about what kids are saying, what their language is, you know, their social media language, and what these LOLs and all these things mean. Parent in room, PIR, that kind of thing. Those are my references. That's pretty much it. So next time we get together, that'll be what we talk about. Dr. Lozzi, you have anything to say?
I mean, I don't have anything particular to say, Dalton. I mean, you covered it pretty well. Are there any specific questions about what we're doing or what we're trying to do?
Anybody have any questions about what's going on in the El Paso area or around this region? What we're... Yes?
So as I'm listening to this, I'm thinking the medications that we are using now, is that not only does it decrease the viral suppression, but it's also decreasing the incidence of AIDS, full-blown AIDS?
Yeah, we want, ideally we want them to come in early enough where that's not an issue. AIDS is not an issue, but Dr. Alozzi can talk to you more about the medication aspect. We typically want a person who has AIDS is much more intensive and expensive to treat than a person who is newly diagnosed, who's linked to care early. You have any comment on that, Dr. Lowley?
No, I think you said it well, which is the goal of everything is getting people screened as early as possible. The screening is what's directly affecting when somebody has AIDS or not. The medications will increase their T cells and they'll come out of it. I think what's important to note is that because somebody has an AIDS diagnosis once, does not mean that they have AIDS for life. And that's a common misnomer that somebody says, well, I've had AIDS since I was diagnosed 10 years ago, and you see them with T cells of 800, right? So AIDS is just a state based on deeply reduced immunity. And once they get on medications, for the most part, they will get their T cells up above 200. The other thing to note is that people that are older, the older you get and the older you are diagnosed, the harder it is to elevate your T cells, even with medications. And so that's why it's critically important that in the primary care settings, urgent care settings, that people get HIV screening and then referred to care as quickly as possible.
You had a question back here?
I was just wondering how y'all are identifying these patients. I mean, is it through screening? Is it through presentation with symptoms? I mean, how are you identifying this group?
Yeah, I mean, I always say that if we're identifying people with symptoms, then we're failing the system. I mean, we're failing them already because the truth is this: majority of the persons living with HIV have absolutely no symptoms. The only time somebody ever has symptoms is usually when they start to get towards AIDS, right? And they get diarrhea, lymphadenopathy, they may have pneumonia, but that's late. Their risk of mortality in the first year is about 50%. The ideal way to do it, and one thing that we have been lucky with in the El Paso region, is that we had a CDC grant that actually allowed the county hospital to do free testing on absolutely everybody that walked through the emergency room. And so we had a huge influx and pickup of patients with HIV that had no idea. In fact, majority of our patients came in either from motor vehicle accidents or asthma attacks or whatever it was, And that's another reason, I don't know if Dalton ever showed you the demographics of our clinic, but we have one of the younger clinics in the state of Texas as a whole, because we pick people up when they're young and very early. So that's the key to HIV pickup.
Yeah, and I would just say to the crowd here that, and people who watch this video, is that back in 2006, the CDC put out that that guideline, that recommendation that everyone who comes in the ER between 13 and 65 ought to have an HIV test. Same with hepatitis. That's been out since 2006. Everyone who comes through my research class, I try to reiterate that. And I've had a couple of ER folks, so they're trying to actually work that in now into a policy. But yeah, any other questions?
Just one question. How can we use social media proactively? Those of us that are into health promotion and prevention, we've heard about how it's used to, for the wrong reasons. Do you have thoughts on how we can use social media to our advantage, those of us that want our communities to be healthy?
Still there?
Can you repeat that question again? I missed half of it and then I broke up because of my signal.
Yeah, sorry. It was just how can we use social media as a positive aspect instead of like the negative things that are coming into to light here that I'm demonstrating. So what are the positive aspects?
I see what you're saying. Yeah, I mean, I think social media, a lot of times in the eye of the beholder, if you have an active social media program, you can create methods. I really do believe in you targeting messages to people that need it. For example, when we were using Google Voice to send out active text messages to patients, we were using that to reduce no-show rates. There are other organizations who have set up Facebook pages or set up Instagrams or set up Snapchats, and they send out positive messages that people can see those positive messages and their patient community can be involved in it. So yes, social media can have a deleterious effect, but I think if an organization has the wherewithal or the people within it, and a lot of times you can get students, right? You can get volunteer students who need hours of social work or whatever it is, community outreach, and they can help you create that message because they're already in that world. And so I think don't get focused on the negative aspects of it, but I think focus on how you can utilize it to actually reach out to the population that you're trying to get to.
Great. Anybody else? Any questions? Yes.
I just wanted to add that on social media, you can always find something positive that if you post on your own Facebook page, and just put something positive out there. Like we have a coalition, and what we do is we try to put out positive messages because we do drug prevention. So we try to put out tools for parents to use to talk to their children about prescription drugs or underage drinking, things like that. So you can always find something that you can put on your page that's positive. And if you're on Instagram, post something positive about sexual behavior.
Right.
Or put something positive instead of saying 45% of men are HIV positive. We can say, 50-something percent of men in our region are not HIV.
Right.
Right. Just trying to switch it over.
Yeah. So there was a comment that was directed towards the last comment, or the last question, actually. So any other questions, Dr. Losey? He's kind of short on time today, so. Okay. Any final comments, Dr. Losey?
No, I'm good. I think it's been a good talk, and I always appreciate the group's time, so thank you very much.
Thank you. Thanks for calling in.
All right, have a good day.
Thank you. Okay, so anything else you guys can think of?
I
Or?
have a question, Dalton, about navigation, about the
Yeah,
navigators.
yeah.
Are you all referring everybody who comes through your clinic that's positive to navigate, or how are you following them up?
Yeah, we actually have the benefit of having federal navigators in the office, and because of this, some of the federal navigators that came out of this are stationed in other places where they have similar programs to what we have, but didn't have a navigator aspect. So because of the size of the navigation program, we can implant those people there, and that's Project Champs is program. The only thing, I mean, all we did was have a conversation or two about things, but they put that into practice, yeah. And I'm just happy to be a part of the whole group as a whole, because I mean, we're really making waves in Texas. DSHS is still kind of scratching their head about how we put all this together in a year.
It seems that a navigator would be so instrumental in keeping them, taking their meds and out of the hospital and healthier for longer. That gosh, a navigator.
If you don't know what's out there, and say you come into the hospital and hey, you've got HIV, you don't hear a thing that person says past that.
It's like cancer.
Right. Yeah. I just went completely blank. So then you have to have a time to comprehend what you need to do. One of the unique things about his treatment program, one of the things I've really seen that was unique about him was he would put people on vitamins. And then when they would come back to their follow-up appointment, he would ask them, how many times did you miss your vitamins? And they'd tell, 2, 3, 4, 15, He'd say, that's great, but when I put you on HIV antiretrovirals, you can't miss them. That's your lifeline, right? So it's programming and moving them towards a behavioral change, right? Like the Procrasca de Clementi stages of change, that model. Yeah, it's very relevant in what we do. But yeah, in case management aspect, that's exactly what you want. You expect humans to be human and go down that spiral and then relapse, come back in the system, go through the behavioral aspect of change, and then you got to have a desire, then you got to want to do it, and go ahead from there. So that's part of the model, right? And it's very unique in how he treats his clients. We've had great success in that area. I've spent a whole lot of time. She can attest. I've been away a lot over the past year, but it's worth it, because now I see, the seed we planted has grown into this gigantic tree that's branching out all over the place. Yeah. And for all you who are in school here, I mean, I got my start right here. This is where it all happened. So. Yeah, very glad to be blue, and that's why I use the blue representation on Texas. All right, any other questions or concerns, comments? Yes, ma'am.
I should know this, but I don't, so you can really good explaining this to me. On the earlier slides, you had the death rates.
Yes.
And the highest was for white population.
Let me get back over there and see.
Yeah, and I heard someone asking the same thing, but blacks are disproportionate in just about everything wrong. I think everything was shown. Wouldn't the death rate be higher among blacks?
Was this the slide, or was it a different slide?
It also showed that people that use drugs have the highest death rate. It was that slide, near that slide.
Okay, let's see.
It was one of the death, but I don't remember exactly which one it was.
Right there.
This it?
There you go.
This one? Why would you, is that it? Or?
I think that there'll be a disproportionate number of black people dying versus.
Because you showed more black people contract AIDS.
Yeah.
HIV, I should say.
So a lot of that has to do with the age at which they get it, like he said, because it's so much harder to get rid of it or to bring you back into a well CD4 count, well T cell count. If you, the older you are, the harder it is to build those back up. So unusually, this population here is contracting it later they're the 45 plus that are getting it, and this population demographically is getting it later. The risks and all the things that are taking place, like I have a whole another lecture that I do it in my research class, and I show how there's different risk behaviors for the different ethnicity groups, and how alcohol and drugs are typically introduced earlier in age in Black, Hispanic populations. Also that, birth control is a big factor in Hispanic population because you have a heavy Catholic religion, that kind of stuff that doesn't promote birth control. So, there's a lot of variables to the equation. So I usually tell people when I'm giving a demonstration or a presentation about something like this, these are numbers that the state gets or they find in whatever regard to where they're given. And what I do is I try to promote the most usable way of interpreting this data. So those are some factors that affect it. Does that answer your question, or do I?
Yeah, we talked about it enough, but I just expected it to be higher.
Maria is our new. She's moving into a different. Well, she's moved into a different role. She was our community planner for several years, all the years I've been there, and is now a contract specialist. Jordan McCann is our supervisor and contract specialist as well. And then Teresa, we share the same star care, but we don't see each other much. But our stuff crosses each other all the time. I mean, we're practically doing the same thing. She's working on alcohol related and teens and stuff like that, right?
We do the coalitions to change laws and policies to keep kids off of drugs and alcohol.
I know.
So we try to mobilize the community to be part of the coalition.
So we should do like a tag team up here sometime. Yeah, that'd be good. Yeah.
One more question. So when children, when you had the ages 0 to 9, so if they're screened and they found they had the virus and they're treated, so and their T cell level drops to a normal range, can they then come off the medication and be off of it?
Unfortunately, it's a lifelong thing.
It's lifelong.
Yeah. HIV has presented some interesting, very unique elements that have come to light in the years that I've been doing this. It builds reservoirs in your body, in the brain, and particularly in some other areas, other tissue areas. And it's not a virus that's easily activated. Like, you can't just go there and say, oh, hey, we want to turn you on or turn you off or whatever. That's a system that they're still trying to figure out. But if you make a person undetectable in their viral load, and then they stop their medicine, and then say they started it again, HIV is unique in the fact that it would figure out how to become immune to that. Then the other interesting aspect about it is that then say you have relations with your husband or your partner, whatever the case may be, and that person doesn't have HIV, and they're not on preventive therapy either, which is a whole other topic in itself. But then you come together and have relations, right? You can pass the immunity to that person in your variant of HIV. So then that drug is no good for either one of you. Very intelligent virus. That's one of the reasons I tell people all the time, don't underestimate HIV at all. I mean, and it's fascinating to me. I mean, I almost wish I was a virologist. Yeah, the things I've learned through this are just, you couldn't even imagine. I mean, yeah, very intelligent virus.
That brought up a question in my head is, if someone is diagnosed with HIV and their partner is not HIV positive, would the doctors be, or would there be assistance for the partner to go in and get preventative medication, so that would be unlikely to give the HIV?
Right, now you would think there is, right? But right now there's not funding statewide for that. There's not funding from the state. There's not funding federally to do that. But what people are doing is paying cash for it.
Is the price of these drugs coming down? I know they were expensive for you.
They're still expensive. Yeah. I mean, you're talking, if you're, depending on what your genetic makeup is and what your other ailments are on top of it, which HIV aggravates everything, you're talking like thousands of dollars a month. I'm talking like $5,000 a month.
But I will say, the drugs, you and I, when we worked together,
Yeah.
and I took care of all the kids in those cases with HIV, and one of our families, they believe the one daughter got it from incest and the son got it gestationally. But she was 5 when we had her in our clinic, and Dalton and I worked together. And I went to a band competition at Friendship High School, and she walked up to me and hugged me, and was now an 18-year-old. So, and if I had not have known that she was HIV positive, because I'd been her nurse many years ago, I would have never guessed looking at her. And it made me really stop and think about, even when kids get hurt, and we just don't even think twice about, these the protective gear. But it just really made me stop and reflect on our practice and how it's people we would not expect.
So I tell people typically when I start these conversations in an arena or like in a venue where there's not nurses and stuff like that primarily, but in other places, like I presented at the state a few times, state convention, and what I typically do is when I open up, I say, does everyone know what HIV looks like? And I said, well, then take a look right beside you, right in front of you, right around you, because it looks just like everyone in this room. And you wouldn't know it. Yeah. And interestingly enough on that as well, when Ebola was a big deal and it was really happening heavy, I would tell people, everybody's wanting a hazmat suit, everybody's wanting a gown and glove, and if somebody had a cough, they were like, oh my God, Ebola on the plane. So, I'd tell people, I was like, yeah, man, I mean, Ebola's here like 2-3 months, and everybody wants to wear a hazmat suit full geared up. I said, but AIDS has been here 40 years. I can't get people to wear a condom. I mean, that's...
That number is horrendous, the males having sex with males. I was like, why do they not know to wear a condom by now?
Yeah.
I'm shocked at that.
Well, and there's other, these avenues that we're talking about, like, primarily this was sort of like maybe a, I guess for lack of a better word, like in gay clubs and in underground little, venues they would go to and have these hookups, and now social media makes it like very out there. Like you can just use an app and say, hey, you want to hook up? And yeah, okay, cool. My place, your place, Motel 6, room 125, I mean, whatever you. Yeah.
Parents really have to know what apps these kids are downloading.
Yeah, I told a story.
I didn't even know. I mean, I didn't know what that those apps were.
And that's the importance.
I thought it was just something to play with.
That's the importance of having these discussions. Yeah, that's why I do this. And the other thing too is I have older daughters as well. So I was a 16-year-old on Facebook when they were going through high school and all that, and I saw everything and everybody because we were friends, and we I followed them. They could not figure out how I would show up at these places and just be like, or I'd be at the mall, or I'd be wherever they were, because I could see what they were. Yeah. Like I had it so bad they thought that like they might throw a banana away in the trash and I might hop up with it on my head, like aha, I mean it was that bad, yeah. But that's a good thing, because like I learned early on, like you gotta talk their language, yeah. You gotta really understand what they're saying. Before emojicons were the little smiley face on iPhone, they were making the symbols back then. So man, these guys don't have a chance. They're
And he's too smart.
I have some cards back there if you guys